Hi all. For those of you who haven't met me, I'm Scott Bragg, a clinical pharmacist with the residency. I've prepared a presentation on changes with hydrocodone rescheduling from a Class 3 controlled substance to a Class 2 controlled substance in a little bit of a different format called Pecha Kucha. The objectives for this talk will be to discuss new DEA regulations, figure out how to manage changing workflow in clinic, and introduce you to a new presentation style where 20 slides are presented in 20 seconds each. And again, this presentation style is called Pecha Kucha. So why was this change made by the DEA? We are all familiar with charts like this showing an increase in overdose deaths from pain meds. These rates have quadrupled since 1999. Drug poisonings are now the fifth leading cause of preventable death in the United States, just ahead of motor vehicle fatalities. In April, the New England Journal of Medicine published a call to action piece by the Department of Health and Human Services. The article talks about strategies to reduce overdose deaths, misperceptions to addiction treatment with medications, and using data-driven tracking to monitor opioid abuse. Their recommendations focus on four main objectives: educating providers to improve their prescribing decisions and monitoring for opioid abuse, reducing inappropriate access to opioids, increasing access to effective overdose treatment, and providing substance abuse treatment to persons addicted to opioids. Some of the problems with overprescribing pain meds comes from the Fifth Vital Sign campaign. This was popularized by the U.S. Agency for Healthcare Quality Research, the American Pain Society, and the VA. Adequate pain control was looked at as a patient right, but data to support significant benefits are lacking. Opioid pain medications can be of significant benefit, but are full of problems. Now, prescription opioid deaths account for over 45 deaths per day. And remember, prescription drug abuse is big business. Street prices vary from $2 to $5 per pill with hydrocodone. Methadone and buprenorphine are available options to treat addiction. Risk of abuse remains with each, but these medications can save lives. Goals of treatment differ per patient, but often these can be tapered and stopped eventually. Some patients may have to be continued long-term treatment, however. Aviso is an IM naloxone autoinjector that patients or caregivers can use in case of an overdose. In patients using opioids or in recreational heroin users, it offers a good strategy to reverse respiratory or CNS depression. Think of this like an EpiPen with bee stings, but watch, it's expensive. The South Carolina Reporting and Identification Prescription Tracking System, aka SCRIPS, is a great resource. It will help you identify and stop diversion of prescription drugs on a state level efficiently and in a cost-effective way. Please sign up for this access and use it when prescribing controlled substances. SCRIPS will report the date that Schedule 2 through 4 medications are filled, who prescribed them, and what pharmacy they were dispensed from. This will help identify pharmacy and doctor shopping and provide a guide to writing appropriate prescriptions in practice. In recent years, the FDA reduced the amounts of acetaminophen in combination products to no more than 325 milligrams per dose. This was due to high rates of severe liver damage from acetaminophen overdoses. Then, in January, the FDA recommended rescheduling hydrocodone due to prescription drug abuse. As a result, the DEA published new recommendations in August in the Federal Register. All hydrocodone products will change from Schedule 2 controlled substances on October 6, 2014. Schedule 2 medications, while still legal, pose the highest risk of potential for abuse and dependence. Retail pharmacies will be stressed on Monday. They will have to inventory all combination hydrocodone products before business hours, change their methods of storing and ordering these meds, and comply with new prescription requirements for C2 medications. One of the big limitations will be prescribing hydrocodone products by midwives and nurse practitioners, who will not be allowed to prescribe hydrocodone products. PAs may write for hydrocodone products if allowed in their agreement with their supervising physician. These prescriptions must be written. We cannot e-prescribe Schedule II medications in South Carolina, use fax prescriptions, or verbal prescriptions. Verbal orders can be given in emergency situations only. You must explain that the delay in treatment will cause undue suffering to the patient, and you physically cannot get the prescription to the pharmacy. When writing these prescriptions, date the actual date you wrote the prescription. You may only provide a 1-month supply per prescription with no refills. Multiple prescriptions can be written with do not fill dates, but these will expire 90 days after being written. These changes present new opportunities for pain assessment and treatment. Patients may benefit from using controlled release medications for better pain control if truly indicated. Tramadol or codeine offer lower potency options. Stopping altogether shouldn't be overlooked as a treatment option as well. So how will these changes impact our practice? Knowing the regulations are one thing, but we're going to face challenges with ensuring safe use and not undertreating pain. These changes will present tough decisions, but in the long run may be for the best. So those are the highlights on this issue and the epidemic we have with opioid abuse. I hope we can all now talk about why the DEA made this change, find ways to manage changing workflow in clinic, and enjoy this new presentation style, Pecha Kucha. Thank you for your attention, and please email me if you have any questions.